Good afternoon, everybody, and welcome to our next instalment of our webinar series. Today, we have the great pleasure of interviewing and hearing from Professor Eugene Athan, who's the Director of Infectious Diseases at Barwon Health. Before I introduce Eugene properly, I'd like to do a welcome to country. I'd like to acknowledge the traditional owners of the land upon which we meet, the Wadawurrung people, and pay our respects to the elders past, present, and emerging. I'd also like to thank our monthly sponsor, Deakin Talent, and also our platinum partner, Pixeled, and all of our corporate partners who allow us to do what we do. Thank you to everyone who's joining us today, and it's sure to be an enthralling session, an inside view of this whole COVID pandemic, and hasn't it been an interesting experience to live through? Professor Eugene Athan's the Director of Infectious Diseases at Barwon Health, and he's been there since 2004. He's a Professor of Medicine at the University of Melbourne and Deakin University. He was also the recent Chair of Healthcare Infection Control Group of the Australasian Society of Infectious Diseases. He was the co-founder of the Geelong Centre for Emerging Infectious Diseases in collaboration with Barwon Health, Deakin University and the CSIRO. Welcome, Eugene.
Thank you, Ben. Good afternoon to everybody.
Well, you've certainly got a strong education and understanding of infectious diseases. How has that been to put it into practice over the last 12 months?
Yeah, it's been a whirlwind, Ben. So I would say that probably for the last 20 or 30 years, our society and scientific community have forecast that humans would face a global pandemic. So to be honest with you, a lot of us within the expert group were not surprised when COVID hit China and then the world. We had seen SARS, we'd seen Ebola. They were relatively contained quickly, but certainly this has been a major challenge for humanity.
And when you were predicting the pandemic, where would this be on the scale of severity?
Well, the severity aspect is just the extent and transmission through the population of the world. In general, it's not a particularly virulent virus for the majority of people, but we do see for people over the age of 70, a significant mortality associated with that.
So that's a really interesting conversation because, you know, I'd like to debunk a few myths as we talk today as well. But in terms of the mortality, how much worse is it than the common cold and influenza season?
It's comparable to influenza in terms of mortality. Overall, in the population, it's about 1 in 1,000 deaths result from infection. But when we talk about people over the age of 70, it's something like 10%. And over the age of 80, it's closer to 40%. So very high in the aged or vulnerable individuals.
And just while we're on the topic of influenza, what are we looking? You know, I know there was a story last year that there wasn't too many cases around because we're all sitting at home and COVID. Should we still continue to look out for influenza and take care and get the shots this year?
Yeah, absolutely. We're starting to see a few cases confirmed through the laboratory surveillance system. So I'd highly recommend to the audience to talk to their GP or get your flu shot if you get it in other systems. It's perfectly effective and safe, and now's the right time to get it.
And it can be taken in conjunction with AstraZeneca or any of the other vaccines?
They've got to be divided by 2 weeks. So you can't have one vaccine without the other, without a 2-week interval.
Yep. So for all of our viewers, do you mind just giving us let's go back to the beginning and give us a bit of an update. What is the COVID, the coronavirus?
So coronavirus relates to the appearance of the virus. It's got little spikes like a crown on the outside. It is related to a lot of the viruses that cause colds every year circulating around the world. And interestingly, a lot of these originate in animals, particularly bats in wildlife. When they cross into intermediate animals or species, then humans can get exposed. And so we believe there might have been a middle animal in China that transmitted initially from a bat to a middle animal, domestic animal, say at a market or a farm, and then jumping across to humans. We do get other milder versions of coronaviruses every year, but it's interesting that they are originating from wildlife. And then it's mutated very successfully to transmit between humans over the last 18 months.
And has there been similar cases in the last decade?
The more similar examples would be the SARS virus that occurred originally in Hong Kong and Singapore and also affected Toronto in travellers. It's from the same family of viruses.
And why didn't they go as to the extent of this one, Eugene?
The difference is the reproductive number. So one case of the COVID or coronavirus that we're dealing with now will result in 3 to 5 secondary cases, whereas SARS was 1 to 2 cases. So it's much more transmissible.
Mm-hmm. And I suppose we hear a lot in the news about where we're at. And, you know, broadly speaking, the vaccinations are due to be completed at Christmas and we've got 2 or 3 million people done at the moment. Where do you see us on the whole scale? How would you assess where Australia's at? You know, are we due to see another wave or, you know, should we still be really cautious?
I think people need to remain informed. So listening to the media and updates and what the public health system is telling them. I think Australia is extremely well placed by global standards. We've managed to eliminate COVID from the population in almost all of Australia. The only leakage we see is return travellers. So as long as we continue the hotel quarantine arrangements, there is always a very small risk of there being a leakage in that complex process of getting people off a plane, through public transport, to a hotel, and then eventually out to the community. There's a lot of workers and contacts that occur in that space. As the vaccine rollout is kicked off, more and more of those individuals working in that space will be vaccinated, including hopefully return travellers very soon.
Mm. And I don't mean to get political, but it's a topic of conversation. At what point, from a medical perspective, can we open up our borders?
I think once 80% of Australians have been vaccinated, we'll be in a very strong position to open our borders and allow international travel. We'll obviously need to look at country by country over time to see what's happening to the epidemic in those countries and their own control measures at the same time.
And what do you think, will 80% be difficult to obtain? Is there a little bit of pushback from some segments in the community?
Yes, unfortunately, that is the case. People are anxious. They've heard lots of things. There's lots of reports. There's been concerns around thrombosis risk with AstraZeneca. So we need people to be well informed and to make the right decision. Excuse me. They'll need to see their GP or attend at the mass vaccination sites to get vaccinated. The information is out there and people need to take their time and make sure that they feel comfortable to get vaccinated. We find that probably 30% of Australians are showing some hesitation or anxiety about being vaccinated. But for the majority, 70% people are happy to proceed. We're really looking for 70 to 80% coverage.
Yep. And that's when we can start to open up borders and start moving around. Is the vaccine the game changer that we're expecting?
It is for nearly all communicable diseases. If you get excellent coverage, you get herd immunity, you stop and eliminate transmission. So a good example of that in Australia would be polio or measles, where we've got 95, 98% coverage among children. And therefore we don't see measles or polio except when it gets imported from countries where it still occurs. So we pretty much eliminated those diseases due to the vaccine.
And for the uninitiated, how does the vaccine work? Because I hear stories you can still catch COVID, but it's not as bad. You can still carry it and transmit it. What's some of the background to this?
The vaccine is quite simple in design, although there's different technologies that have arrived at being used in this latest generation. As I mentioned earlier, coronavirus has little spikes on the outside called spike protein. And basically each design of vaccine uses the same protein presented to the immune system so that our bodies produce antibodies as they do to any other virus, like the flu, for example. So in the messenger RNA, it triggers our cells to produce the protein. In the AstraZeneca version, it produces the protein independently. So either way, our body's recognizing the external part of the virus consistently, and we're seeing protection levels of 98%. That's a very good coverage. That's a very good success with the vaccine. And that includes both AstraZeneca and Pfizer.
So just so I'm clear, 98% chance that you will not get the virus.
Yes, that's right. So the vaccine does two things. It protects against disease or symptoms, but it also reduces transmission. Okay. Certainly getting into the range of 95% plus. And we've seen that in Israel and Scotland, which have got mature vaccine programs where the majority of the population have now been vaccinated.
Wow. Okay. That's and are all vaccines equally effective?
They're all in the same range. So we consider a vaccine to be effective if it's more than 95% effective at preventing transmission. Both the candidate vaccines we're using currently have achieved that in the trials, and we're seeing that in the broader rollout. So they are similar. Obviously, they have different mechanisms, as I described, and different reactions in the host.
Yep. Now, ladies and gentlemen who are tuning in, please use the chat function if you've got any questions for the professor. Sandra, I hope we answered your question there by suggesting that after a couple of doses of AstraZeneca, there should be a 95% chance that you won't be passing on the virus. That's true, isn't it?
That's correct. That's absolutely correct. And it's been shown now.
Yep. So, Professor, are there any certain medical conditions where you shouldn't be taking the vaccine?
Yes. So there's only really two important conditions. Number one is an allergy to any components in the vaccine. So if people have been known to be allergic to any of the components that we use in the delivery or the adjuvant, which is the chemical linked to the vaccine, we inquire about that in every instance. That's pretty uncommon. And the second one is people have had problems with heparin. So heparin is a drug we use to thin the blood in people in hospital. So if they've reacted to heparin in the past, it seems to be the same mechanism that triggers that thrombosis or blood clot that we've seen with AstraZeneca. These are very rare conditions.
And what are the figures around the blood clots?
So the blood clots in the Australia-wide population, it's about 1 in 250,000, the risk of developing a clot with AstraZeneca. If you go to under 50, it's probably closer to 1 in 200,000. So we've created a threshold to recommend AstraZeneca in people over the age of 50 in general. And if they're under the age of 50, we're using the Pfizer vaccine. That's across the whole population.
And just to recap, the Pfizer vaccine's due October, November this year?
We've already had Pfizer available in Australia on an arrangement with the company. We've got 20 million doses agreed to from the start of the year, but it's coming in small quantities to each state. We're getting a second lot of 20 million doses in October. So that will shore up coverage of the broader population.
Yeah. Now, just on that, do you mind me asking, are you privy to the argy-bargy that's going on in regards to getting the vaccines by nation states?
No, not specifically. I'm aware that there is quite a lot of discussion at the European Union level about releasing vaccine out of European production, where we're in competition with European markets. And you could argue from an ethical point of view, countries that are in the middle of an epidemic with lots of caseload, who've got major disease and filling up their hospitals, maybe they're the priority. Australia has pretty much eliminated COVID from the population. So we've got more time to sit back and wait for things to unfold while we get a stable vaccine supply.
Yep. Now, just on anti-vaxxers, and I don't, tell us a little bit about why they would be choosing and some of their arguments for not getting the COVID vaccine.
So I think there's two segments in the population. I mentioned earlier that about 70% of Australians are happy to get on and be vaccinated. 30% seem to be hesitant. They've got concerns. They've heard different reports. I think that those folk, we've still got some work to do about getting the messages right to the public about reasons to be vaccinated and choices. And then there's a very small percentage of about 5% who seem to be serious anti-vaxxers that have a problem with technology, modern medicine and science more broadly, and they sort of loop it into conspiracy theories. That's a very difficult group to have a constructive debate with. If I'm not sounding too judgmental, that would be my take on that.
Yep. And have you had a shot?
Not me directly. I think it's difficult to enter into too much debate where there's not a proper dialogue. We have had anti-vax demonstrations at times in recent weeks during our vaccination campaign, but they've been mainly fairly civil. There hasn't been too much disruption or any violence.
Now, in terms of the rollout, we were advised at the very beginning that this was going to be a monumental logistical challenge for the government, but health professionals like yourself. Is that how it's turning out?
Yes, it's a logistic challenge, but I think health services are good at their job, and we've got lots of enthusiasm and goodwill, and the state and Commonwealth government have significantly resourced our ability to roll out vaccine in both metropolitan, regional and rural Australia. And we're doing very well in the Barwon Southwest region at the moment.
How many, generally speaking, how many people have been vaccinated on their first dose here?
I'd have to check our numbers. We've vaccinated over 5% of the Barwon Southwest region. We're on track to almost 10% of the whole population.
Wow. And we know, so perhaps take us through it a little bit. I know GPs are able to deliver, and then we've got the Ford factory being used as a mass vaccination hub. Is that correct?
Yeah, that's right. So we're aiming to get the Ford mass vaccination site up to doing 2,000 vaccinations a day. We're currently running at over 1,000 vaccinations a day. We have streams for both AstraZeneca and Pfizer, as I mentioned, the age cutoffs. The GPs are increasingly capable to roll out vaccination across the region. We're also launching the mass vaccination at Warrnambool that started yesterday, another site.
Yep. So take us through it. What if you walk in the door of the old Ford factory? What will you see, and what will happen?
You'll see that it's quiet, that it's a very large space. It's in pretty good nick because we've done some refurbishments. You'll be asked to park into the main car park, and then you'll follow signs and arrows into an orderly queue. You'll be registered and met by administrative clerks. You'll be asked to give some details, sign a consent form, make sure you understand the vaccines, its potential effects and benefits, and make sure that there's no reasons that you can't have the vaccine. You'll then be immunised, and then you'll be sitting in an area which is well spaced for 15 minutes to make sure you don't have any early reaction. And then after that, that system records your vaccination of dose 1, and that goes to the Australian Immunisation Registry, which is a permanent record for everybody about their vaccine status. And then you'll be given a time to come back either in 3 weeks for Pfizer or 3 months for AstraZeneca to get your second dose.
Very good. Great description. And do people need to book?
Ideally, yes. 80% of our vaccinations happening through bookings, but we're happy to take walk-ins as well. We're allowing about 20% of the 1,000 to be walk-ins at the moment.
So you're kind of suggesting people can be in and out in sort of 30 minutes?
Yeah, all going well. I was there this morning, and certainly people were coming through in less than 45 minutes.
Okay, wow. So getting back to the, let's focus on AstraZeneca, I suppose, because that's the one we hear about it a lot. As a business, when staff are going to get their vaccinations, should a business person be preparing for that person to have a sick day the next day, or to have some side effects that may affect their work?
So as part of the consent process, we inform people they may have mild reactions. Common side effects would be aches and pains on day 2, day 3, and a possible low-grade fever. Most people otherwise keep active and normal. If they do have significant symptoms, they're probably best to rest. They don't necessarily need a COVID test unless they've got a cough. In any case, I think it is reasonable to assume that probably up to half of people may need 1 day by day 3 or 4 to rest up post-vaccination with AstraZeneca. There's a big proportion, at least half, that have very minor or no reaction whatsoever.
So this might be a legal question, but can businesses make it compulsory to get a vaccine?
Not yet in Australia. There's been no appetite to mandate the vaccination, although I think going forward it will get increasingly complex in high-risk environments such as aged care, border control, to allow workers to continue in that environment. But it's not currently mandated in any work environment.
And forgive me, but is it compulsory for workers who are unwell to get the test if their employer asks for it?
This is the COVID test?
Yes, yeah.
Yes, that's right. Under the Public Health Act in Victoria, if there's a concern of COVID, then the testing can be mandated by the authorised officers that are involved. For example, as part of a contact tracing exercise, it would be compulsory in terms of the Public Health Act to be tested.
Yeah, very good. And do you think it's going to be a case with these different strains that are coming through? And look, I don't know much about the strains. I think there's UK and South African and Indian. But do you think it's likely we're going to need to be vaccinated every year on year?
Yeah, so they're kind of two separate questions. The vaccines themselves seem to produce protective antibodies for 2.5 to 3 years. So I'd expect that going forward, people will require a booster dose at about 2 years. That's likely to be the scenario until we see new generation vaccines, which are now slowly coming online. The question about the variants that are around the world, most of the variants where they've been studied, the vaccines are effective in protecting against the known variants. As the virus lives with humans longer and longer, there is the possibility of further mutations over the next decade, which will mean we'll have to get smart with new vaccines. But that's not relevant right now.
Yep. And a basic question, can you get multiple vaccines, AstraZeneca and Pfizer?
Yeah, that's an interesting question, Ben. So there's been a couple of small studies to test out whether or not different technologies give a better immune response. And the early stages suggest that it does give a good immune response to combine them, but we're not recommending that because that's only early days and very small studies. All the large clinical trials showed 1 vaccine, 2 doses, showed excellent, robust immunity. So I wouldn't be recommending for people to chop and change.
Okay. And should children get vaccines?
Where we're up to at the moment is the initial trials globally were over the age of 15. So we're happy to offer the vaccine to kids over the age of 15, 16, once we roll out to the broader population. Currently, there are studies in North America and Europe taking the vaccine down to the age of 12. So we'll wait and see if it's safe and effective in that age group. But I would expect that it will be.
Yep. So if you don't mind, I'll just refer to a couple of questions from the audience, Professor. Are these vaccines classified as experimental? I've heard this is the case, and therefore if someone were to have an extreme adverse reaction, they cannot claim on insurances.
No, they're not experimental. They've gone through all the regulatory trials, so based in laboratory, animal studies, healthy volunteers, and then large-scale phase 3 trials globally. Many thousands of people have shown that the vaccines are effective, as I described their efficacy earlier. So they're not considered experimental. And under all of the regulations within Australia, if you do have a complication or a side effect, that will be covered both by health insurance and by Commonwealth regulation.
Okay, and secondly, you touched on it in the beginning, but I don't think you put a figure on it. But over 80s, the mortality rate for influenza, COVID's about 40%. Are they kind of similar levels?
They can be similar, particularly if the diagnosis is delayed and people are, for example, in aged care. We would see a very high mortality. It does respond to antivirals. So we have antiviral drugs for flu, for influenza, but you've got to start them early if it's going to turn the disease around. Yep. We don't have treatment like that yet for COVID.
And I know we put on another 300 beds in intensive care in the very beginning, and congratulations to Bowen Health in their preparation for and throughout this whole pandemic. But we're seeing a human tragedy unfold in India at the moment, and we keep hearing about lack of oxygen and so on. Is that the issue? Is that the best way to treat someone with COVID?
It's quite a complex question. So the important thing is what is done at the very early stages. So obviously, locking down the cities to reduce interaction will reduce spread and numbers of cases. Once you've got COVID, if you're a healthy individual, you can rest at home, but anyone who has complications needs to be assessed medically, and then they may require hospitalisation and oxygen and going onto a ventilator. So that's a small percentage of individuals, say 10%, but if there's no access to that additional ancillary care, people are at risk of death. Wow.
And I suppose the India issue, because India has 1 billion people, becomes a global issue, doesn't it? We need to work together to assist them.
Yeah, I think the Australian government has made contributions in terms of consumables and including oxygen. But as you say, it is a global problem because not only do we need to assist people in India for their healthcare and their suffering, We also have to be mindful that return travellers coming to Australia may bring new cases of COVID to Australia from a high endemic country at the moment. So we can't work in isolation. So good infection control in India is going to also help Australia come through to the next phase of recovery.
Will there be some nations around the world, poor nations, who will be living with this for many years to come?
I think certainly over the next three to 5 years, that is likely to be the case, where there's a lack of containment processes, testing ability, and it's very difficult to lock some places down, some communities, due to poverty or lack of resources or health systems.
Wow. And I suppose, as terrible as this is to say, everything's an opportunity to look at the way you do things and improve systems. And we know that through terrible wars and all that sort of stuff. This pandemic, you said you were modelling it leading up to the true event. Has this been a learning experience so that we're in a great position to have the right systems in place should something more solid come our way?
I think so. I think the global community has been caught ill-prepared, and many lessons have been learnt about global cooperation, alerts, and being able to contain an emerging infection early. So if we'd acted more strongly in the first, let's say, 1 or 2 months, that might have switched off the pandemic early. So that sort of degree of communication and approach would be an important global learning, so global cooperation. Within Australia, I think we've invested in strengthening our public health system. So we had a very centralised one in Victoria. We're now looking at a decentralised model so that, for example, at Barwon, we now have a local public health unit, and there are now 9 in Victoria. So that will, I think, add to our ability to identify and manage emerging outbreaks going forward. I think there's been an investment in both biotechnology and in the public health infrastructure in Australia that will better prepare us for the next potential threat.
Yep. Do you have a wish list of any items or funding that you think would better prepare us moving forward?
I think the funding should go towards the training and education around pandemic preparedness as a starting point. We also have problems where the IT systems are really designed for simple, crude number crunching. I think going forward, we need more sophisticated IT systems so that we can contact trace in a seamless way using things like Bluetooth technology. The COVID Safe app did not achieve what we had hoped for, the Commonwealth software program. So I think some investment in that would have made a big difference. I think the biotech capability of Australia is still underdone by Western standards. And so I think investment in vaccine technology, antivirals would be great to see in our part of the world.
Very good. And you are talking to businesses here today, and that's who we represent. But businesses are people with families and so on. But it's all about confidence now, isn't it? Should we have greater confidence in our system and our processes to be able to get back to business and knowing that in the next 6 or 12 months we'll things will return to some normality?
I think that the Geelong business community can be assured that the contact tracing system in Victoria is now quite robust. We can deal with a small number of cases with excellent and rapid contact tracing and testing. We've got rapid turnaround now. I think now with the vaccine rollout, just be sure that you make sure your workers are offered vaccination and have opportunities to do so, even if that means a day off to recover from any minor reaction. And I think certainly by the end of this year, we'll be in a very strong position to return to business as usual, certainly within the Australian context, let alone putting aside the consideration about international travel.
Yep. That's a good message to employers to make sure that they're encouraging their staff and to get the vaccinations. Is there any other parting advice you have for our listeners here today, Professor?
I think mainly just be well informed, follow up on reliable sources like the state government and the Commonwealth government around COVID information and the vaccines that are being made available. I think that's number one, so that you make a considered decision for yourself and your family.
Mm-hmm. Well, thank you very much, Professor Eugene Athan, who's the Director of Infectious Diseases at Barwon Health. Thank you, Professor, and well done to yourself and all of the team at Barwon Health for a great 12 months, and we feel we're in pretty good hands.
That's a pleasure, Ben. Thanks.
Take care. Thank you, everyone, for joining us, and have a great day.